we are moving on to genetics, and Dr. Sankar, HOD and Professor Medical Genetics will be talking to us on genetic evaluation and pediatric ophthalmology. Over to you, Sankar.
Good afternoon all. At the outset, I thank my teachers, Sanam sir, other faculty and this KSOS for giving me the opportunity to talk in this august audience on genetic evaluation of in a ophthalmology case, especially pediatric ophthalmology. So what are the learning objectives? What I am expecting in this 15 minutes, not to learn the entire genetics, which I think it is definitely it's not possible. Just to understand the genetic counseling is important for any clinician, including an ophthalmologist, in some situations where they will come to you, how to go about. Then importance of definitive diagnosis in the affected person. Without that, a child or a father is blind. Just we cannot counsel them properly. We want to know what is the definitive diagnosis at the genetic point, which I will illustrate in 2 or 3 cases. And what are the points to be discussed during genetic counseling scenarios. And finally, 1 or 2 sentences on recent advances in gene therapy, which we are not routinely doing it, but it is the things which is going to come in next 5 to 10 years. So what is actually a genetic counseling, which everybody should practice? It is just a communication process to inform the family at risk of occurrence or recurrence of a genetic disease, a person about diagnosis, natural cause, treatment and its outcome, risk of recurrence, ways to prevent the recurrence, etc. And for properly doing this genetic counseling, because as an ophthalmologist, the couple may coming to you or saying that both of us are blind. What is the chance of developing the same problem in the child? At least you should have some idea how I will go about it. So you should know that what is the cause of the blindness is we have to identify. At the genetic level we have to identify. So, or they will come with a genetic report. At least you should be able to read what is the report, how to do that. So during this, to provide accurate information regarding the disease, how it, natural history of the disease and how it occurs, etc. There are so many things, just like any other disease, family history, pedigree analysis, detailed history, gathering information, physical examination, reviewing the latest literature, etc., etc. But most important, crucial thing, which I think the today new generation doctors should learn, is the appropriate diagnosis of genetic test. Because these company people or the lab people will say that you can do microarray, you can do exome sequencing, whole exome, whole genome, everything can be done, which is costing fundas cost of 20,000, 30,000, 40,000. But actually it is useful or not, and how to read it, that everybody should understand. So there are so many genetic tests are there. Even 15, 20 years back, we cannot have this much genetic testings are not available. But now we are having from karyotype, FISH, microarray, optical genome mapping, newer tests are there, then RFLP, TP-PCR, invasion. Don't learn all those things, just to understand that there are various types of genetic tests are there. But most of the time, nowadays, we are using the next generation sequencing, panel testing, clinical exome, or whole exome. It is just for an introduction, where I will go to some of the case scenarios. Even though it's a pediatric ophthalmology, I've taken some of the couples also, because that is a common thing which will come for genetic counseling. Because they want to prevent the disease in the fetus itself. I think it is more than pediatric ophthalmology. A non-consanguineously married couple came for preconception counseling in view of both the partners or the history of visual impairment. So both of them are having visual impairment, and they had a history of spontaneous abortion, and they are very much worried that what about their child's, whether they will have. So most important thing is you should have a detailed evaluation including genetic testing in the both couples, both persons. So in the husband, it's a 31-year-old male born of non-consanguineous marriage. Presented with, I have seen the previous history and everything I have taken, reports I have seen. It's a bilateral congenital cataract, and his sibling is also similarly affected, which I have shown in the last pedigree. Whereas the girl, the wife, 31-year-old, non-consanguineous marriage, she had a bilateral retinoblastoma, detected at 3 months and 4 years of age respectively. Surgical intervention was done. There is a family history of cancer in father who diagnosed with myeloma. So actually both are 2 different conditions. We have to tackle this in 2 different ways. Directly we cannot say. Retinoblastoma is one thing, congenital cataract is different thing. So retinoblastoma is one of the important conditions where genetic testing will help you a lot. Because retinoblastoma is a condition, is a hereditary cancer-prone disease where it is autosomally dominantly inherited. One mutation will be inherited through the germline, and second mutation will have in the eye, which causes the disease. That is called a Knutson's two-hit hypothesis. That is, one is mutation is inherited and another mutation comes in the tumor. So basically it is in the tissue level, it is an autosomal recessive disease. That is, both the genes will be mutated, but it's an autosomal dominant inherited disease. If the mother, if wife is identified with the mutation in the germline, there is 50% chance that the offspring will get that mutation. And if they got the mutation, they have got a high chance to develop retinoblastoma or other diseases, other tumors like osteosarcoma, rhabdomyosarcoma, etc. So definitely retinoblastoma has to be genetically, testing has to be done. So in all patients it is there. Basically there is a phenotype-genotype correlation is there. Whenever you are having a multifocal bilateral retinoblastoma, it is almost 100% chance that there will be a germline mutations will be there. Whereas if it is a unilateral, unifocal retinoblastoma, there is only 15 to 20% chance to get the germline mutation. So definitely in bilateral diseases, early diseases, multifocal diseases, invariably genetic testing is mandatory to do. So next thing is RB1 gene. What are the mutations? There are different types of mutations are there. It is not a single point mutations. It can have a deletion also is possible. So sequence analysis alone is not possible. You have to do MLPA also to look for what type of deletion they are having. And if you identify the positivity, for example, in another case, I have shown this case, we have got another case where they are actually from Thrissur. First baby is having a retinoblastoma followed by osteosarcoma. And then only they came, the RCC people have referred, we have done the mutation, it is RB1 gene mutation positive. Younger child is 3 months only, so far there is no retinoblastoma, but it is RB1 gene positive. So that child needs regular cancer surveillance. You have to have every 3 to 4 weeks, age 6 months, every 2 months from 6 months to 3 years, and every 3 to 6 months from 3 to 7 years. So regular follow-up surveillance. So this also can be, we can tell them if you properly genetic testing is done. Coming to the husband situation, congenital cataract, it is not like retinoblastoma where single gene. There is only have to only RB1 gene, not mutation. Whereas congenital cataract, it can be a non-genetic also. Intrauterine infections, galactosemia, hypocalcemia, diabetes, so many conditions can produce cataract. Isolated cataract can be a syndromic cause like Zellweger, Lowy, Stickler, RCDP, myotonic dystrophy, etc. Or it can be an autosomal dominant X-linked recessive. So many genes are known for this condition. So here if you go to the OMIUM, that is for PGs, if you want to know anything about the genetics, you go to www.omium.org, you put the congenital cataract, you will get all conditions where cataract is there. So here it is, you can see that there is 244 entries are there for congenital cataract. That means there is 244 genes, 244 loci is there for congenital cataract. It is humanly impossible to look for one gene to next gene to second gene. So that is why previously we cannot do that. But now the advent of whole genome sequencing or whole exome sequencing by next generation sequencing, we can do multiple parallel sequencing of the entire genome to look for all these genes affected or not. So here we have done the genetic testing. Husband, you can see that it's congenital cataract 18, autosomal recessive, 2 mutations we have identified. We will call it as a compound heterozygous mutations. Both are pathogenic variants. And his brother is also affected with the congenital cataract 18. And wife, RB1 gene, it is a 3' splice site mutation, hereditary retinoblastoma autosomal dominant. So here we can confidently say that cataract you don't have to bother because it is an autosomal recessive disease and wife is not a carrier of that gene. So 100% of the children will get one of the variant and they will be carriers of the variants, but they will not have any congenital cataract. But retinoblastoma, there is 50% chance that offspring will have that gene and there is a chance of developing the tumor. If they want, they can do prenatal diagnosis. If it is affected, if they want, they can opt for termination or those type of things. So this much perfect prenatal diagnosis can be done only if you do the genetic testing. So in counseling session, we will tell all those things. And another scenario, similarly, another couple came, it is a night blindness and the diagnosis is retinitis pigmentosa. But retinitis pigmentosa or inherited retinal disease is much more complicated, because too much complicated genetic disease. So much research is going on because it is having locus heterogeneity, allelic heterogeneity and allelic disorders. That means there are more than 100 loci with same type of retinitis pigmentosa, and in same gene, different types of mutations can cause different type of disease. In the same gene, sometimes it can produce autosomal dominant disease, sometimes it can cause a autosomal recessive disease, and same gene, sometimes it can even cause a severe macular dystrophy also. So different types of complicated genetic inheritance is explained for retinitis pigmentosa, but here also genetic testing is mandatory to look for which is the genetic disease. Autosomal dominant, recessive, X-linked, all types of inheritance is available, and this is the percentage. So preferably we will use to the panel testing of multiple genes by next generation sequencing to look for any gene is involved or not. In this patient we have done, but you see, interesting thing is that person is getting two genes. One is CRB1, which is homozygous, likely pathogenic, retinitis pigmentosa 12 autosomal recessive. Another is PROM1, heterozygous, likely pathogenic, macular dystrophy. But I think, I have discussed with one of my friends also, you can differentiate with the phenotype. So here deep phenotyping is very important, because whether its macula is spared or not, it is more fitting into the second condition or more fitting into first condition. Maybe an ophthalmologist help is definitely needed to tell that which is the more significant, because in which both is pathogenic variant we got. And this is one of the literature I have seen to see that. When I have got, I'm very happy to say that if you see the ophthalmologic genetics literature, there are so many Indian literature is there. So much Indian literature. So I have put only Indian literature in this presentation, because there are so many studies are there. This is one of the largest study from Sankar Netralaya, where they have done around 250 patients with the retinitis pigmentosa, and because our population and Western population will be a little bit different, percentage will be different. So USHR2 is one of the commonest gene, CRMK is one of the commonest gene, our CRB1 is 6%, PROM1 7%. So both is present in our population. So definitely it is there, and it is different types of mutations, missense, nonsense, frame shift, all these things are reported. And why it is important? Because rate of progression based on the genotype is different. So if you see the USHR, we know that it is a little bit later onset, slowly progressive. And some of the conditions like RP65, RP, both types are there. Some of the genes are very severe progression is also there. And this article ends with, these are the, in their literature, these are the common genes which is having a rapid progression, and these are the genes PRF, PF1, PRPH, USHR2, etc. are the slowly progression. But the last sentence they have told, it is still very uncommon in India due to financial constraints as well as the unfamiliarity of the treating ophthalmologist with the genomic diagnostics. But I think it is absolutely, it is not financial restraints, because now the NGS cost, we are doing it only for 7,500, which I don't think it is not at all expensive. And we are doing more than 20, 30, 40 cases per month for various conditions, not ophthalmology, various conditions. Everybody is accepting. It is not very expensive. 7,500, I don't think it is very expensive. For this much information, you will get it. So we should routinely do the genetic testing for inherited retinal dystrophies. So last two simple cases, for completion's sake, it is one another case with the congenital Leber's congenital amaurosis, where we got RPE65 as the mutation. And you know what is the importance of RPE65, because since molecular pathology we know there are so many gene therapies coming for so many retinal diseases. And one of the important thing which is already in phase 3 study, phase 3 or it already is FDA approved, is Leber's congenital amaurosis, Luxturna, which is also available in India also by the Novartis, which is actually we have to give the subretinal injection and considered to be the therapy of it. And last case, it's a 1-year-old male child born of non-consanguineous marriage, presented with the clinical indication of failure to thrive, global developmental delay and hypotonia, ophthalmic evaluation, bilateral cataract, biochemical evaluation shows proximal renal tubular acidosis. So congenital cataract may be syndromic also. So here just I want to show you, in the simple congenital cataract we got 234 entries. But if you put congenital cataract with renal tubular acidosis, there is only 4 entries. So that is the importance of literature search, especially juniors. When you are going to the OMIUM or somewhere, specific diagnosis you will get if you put the proper things, because these are not expert system, these are all systems for experts. You don't feel that all these AI just give you the diagnosis. AI, we should train it properly, we should ask it properly. Everybody knows ChatGPT is also like that. So if you put it correctly, these two diagnoses, this child is having a heart signs, renal tubular acidosis and this. And why I have put this case is, this is the most interesting case for me as a pediatrician, but I put it last because probably these syndromes you may not be interested. But this type of syndromes, multidisciplinary approach is very important. Ophthalmologist, pediatrician, nephrologist, developmental stimulation, pediatric surgeon, etc. Everybody should combine together to do this. Here also genetic counseling can be done, carrier status in the mother. And this is the gene review. Whenever you are having some genetic disease, you can go to the gene review, which is actually a textbook of genetics. You will get all information regarding any genetic conditions in gene review, www.genereview.org. So take home message is importance of appropriate genetic testing and genetic counseling in ophthalmic disorders with genetic etiology should be a practice in day-to-day practice today, so that we can do a lot in counseling, prenatal diagnosis and definitive testing. And definitive diagnosis is very important, and anticipatory management we can do, prognostication we can do, and recent development of gene therapy, which should be the boom in era next 5 to 10 years. Importance of deep phenotyping and literature search in diagnostic pathway, both are important. Even though this is there, deep phenotyping, detailed examination is very important. Multidisciplinary care is important in patient management. So always we should collaborate and we should work together to get these patients benefited. Thank you very much for patient listening.
One or two queries. Regarding therapy for along with this evaluation and the genetic counseling, what are the in RP for a small segment? As of now, we have gotten treatment to offer. Other than in ophthalmology, are there any recent developments where genetic therapy helps in treatment other than diagnosis, prenatal maybe, because prenatal diagnosis helps in the appropriate way this is managed. Otherwise, in other segments of pediatric, pediatrics.
Okay, lot of innovative therapies are coming. Actually, one thing is our enzyme replacement therapy. So we are giving for lysosomal storage disorder, more than 20-40 disorders are there. Around 10 conditions we are having lysosomal storage disorders, where we are regularly giving enzymes like Gaucher disease, Pompe disease, etc. Similarly, we are having lot of innovative molecular therapies, like in plexiform neurofibroma, we are giving selmutinib. Selmutinib is a MEK inhibitor. Similarly, targeted molecular therapies, we are having so many therapies are there. This is coming one by one. In cancers is there. Then if you come to gene therapy, around 40 gene therapy molecules are FDA approved. 40. And one of these is Lextana. In spinal muscular atrophy, we are having ASO, nusinersen. Risdiplam is a molecular therapy. Then for achondroplasia, this vosaritide is there. DMD, there are so many antisense oligonucleotides coming. Cystic fibrosis, ivacaftor, that is I told. Because in 2004-07, I have completed my DM. At that time, even we are presenting the seminar as a hype or hope. But now in last 5 years, from 2017-18, after this Moderna vaccine, because Moderna mRNA vaccine, lot of mRNA molecules are coming. Lumisarin for primary hyperoxaluria is there. Cystinosis, a mRNA molecule is there. Then for so many conditions, hepatic porphyria, Genevostat is there. So many new molecules are coming. All are gene therapy molecules.
So, are they available in India and are they affordable? Because this spinal muscular and all, we always hear in, it's always in news, no?
Sir, that is true, but it will change, because Risdiplam, it was 6.2 lakhs 2 months back, but now NACO is an Indian made is 11,500 per bottle. So naturally, make in India process, everything will come in India. So definitely it will be more affordable. Now it is very, very expensive, including Lextana, as you know, yes. It is very, very expensive. And gene therapy for spinal muscular atrophy is 16 crores. It is very expensive. Everything is expensive. Gene therapies are very, very expensive. But rest of the molecules are reasonably affordable, molecular targets. But definitely it will come to the Indian market in a reasonable price in next 3 to 5 years. Because we are having rare disease program that is called the NPRD policy, National policy for rare disease, which is we are also designated as a center of excellence for rare disease, where all these things are there. So Government of India is also CDSCO, everybody is easily giving more of a, what you can say, rapid permission for these type of drugs. And Indian make is having a lot of benefits are there. So definitely probably this Luxturna also will be coming in Indian market by the Indian company at the earliest. Thank you.
Now I request Sasraman sir to hand over a memento to Dr. Sankar as a token of our appreciation.
We have got, so I didn't want to encroach upon, now we have got 2-3 minutes more, and we will take a couple of questions. Maybe a question and we will see how time is.
Thank you, sir, for the very enlightening talk. Sometimes when we come across children who have undergone genetic testing, the report comes as mutation of unknown significance. And they might have a strabismus or something, which is not reported when we search in the net. So my question is there any site like OMIM where we could go for for a more credible evidence? Second is how to do genetic counseling for this patient. Unknown significance, would we insist on other?
Correct. So this variant of unknown significance is a major issue even now throughout the world. Because there we don't have, that means we don't have sufficient literature to say that that variant is disease causing. So practically speaking, we cannot do prenatal diagnosis based on that. We cannot confirm the disease based on the variant of unknown significance. So for a practical clinical sense, if it is a variant of unknown significance, you don't have to consider it is a disease causing. Only thing is after 1 or 2 years, you can do the reanalysis of the variant so that sometimes it may change to pathogenic. Because how it is being to variant of significance to pathogenic, when multiple people put the same entry into the ClinVar or various databases, then this 10 people have told that same strabismus is due to this gene, this gene, this gene, then it will become the likely pathogenic. So that is very difficult, very crucial situation, very difficult to counsel that situation. And the databases, there are databases, you can use the ClinVar, I think ClinVar. ClinVar is these are all NCB free databases. Paid databases are there, I don't think clinician that is useful. You can go to the NCB same date database where PubMed, OMIM, everything is there. There you can put, you can say ClinVar, CLINVAR. ClinVar is the normal variant database. You can see in that variant database what is the things. Then there another called the Franklin is there, which will help you to change whether it is any change of this variant has occurred.
Thank you, sir.